This is a case of a rhegmatogenous retinal detachment in a pseudophakic patient. A standard 3-port vitrectomy system is set up, and once the cannulas have been inserted, we use a 3D wide-field viewing system in order to begin the vitrectomy. As you can see here, some subretinal fluid has already entered the macula, but the fovea is still attached. The core vitrectomy is completed, and then a peripheral vitrectomy is done, and the periphery is inspected. In this particular case, the patient had a bed of superior lattice with an atrophic hole inside it, as well as an inferior nasal retinal break that was the most likely cause of the retinal detachment. Triamcinolone was injected to aid with visualization of the remaining vitreous and to make sure that there was no vitreoschisis. In this particular case, very little peripheral vitreous remained. With the help of an assistant, scleral depression is performed for 360 degrees, and the vitreous is shaved down to the base, paying particular attention to the areas of detached retina and the peripheral breaks. In this particular case, seeing that it was mostly a nasal detachment and all retinal breaks were rather small and anterior, the decision was made to make a posterior nasal retinotomy. Once the retinotomy was made, a fluid air exchange was initiated and the subretinal fluid was drained from the nasal retinotomy. The retina was flattened and any remaining subretinal fluid was drained from the retinotomy in order to ensure that there was no remaining detached retina. After subretinal fluid was drained, endolaser was applied to the retinotomy site, as well as the peripheral pathology that was noted on inspection of the periphery at the beginning of the case. After the laser is completed, one more final touch with the taper tip to remove any remaining fluid, and once everything was determined to be dry, 20% SF6 gas was flushed through the vitreous cavity. The cannulas were removed and the case was completed.